one of my video here, I take the opportunity to you know fulfilling the people missing today. Just for a younger people, we deal with a small pupil sometimes. But this was a small pupil case. Normally, we like to do surgeries without manipulation. Though this was a rigid pupil around 3.5 millimeter, I thought I'll do a smaller rexus and do surgery without messing up with the pupillary plane here. So I was trying to do a rexus here. So I could succeed in doing around 3.5 millimeter rexus. Then I realized this was a case for toric implantation. So toric implantation is always difficult in small pupil because you can't see the edges. So I thought of doing hooks to expand the pupil. The classical teaching is to do 4 hooks. Here I am putting 6 hooks. The important thing here to learn, few things are very important for young people sitting here. The incision is posterior limbal. So once you inject the iris hook, they will be parallel to the iris. They won't tent the iris tissue. This is also important for subluxation where trying to fix the bag. If you do a little anterior incision, that is tenting the bag and you can tear the capsular rexus margin also. And same holds true for iris hooks also. You can see I'll put all the iris hooks inside first, then slowly one by one I'll retract the iris hook so that pupil is expanded uniformly without putting a lot of stress into the sphincter here. If you just pull one, the entire iris tissue come to one side. The pulling the second one, you can damage the sphincter here. And normally put 6 hooks nowadays. It gives a very nice hexagonal appearance as you have in various expanded devices. 4 hooks are good, but 6 are much better in making pupil very nice hexagonal appearance. You can see a beautiful hexagonal appearance. I'm staining the capsule again. You see that rexus was around round, very nice, around 3 millimeter. I'm trying to enlarge the rexus again. So this is one teaching here. Whenever you have a difficult situation, visibility makes a huge difference for a completion of surgery in a nice manner. So I've made around 4 millimeter rexus here. I'll do a phaco. Phaco is very simple once you do a good hydro procedure in these cases. I want to give you tips for doing a proper implantation of toric lens under the viscoelastic and how to remove hooks, when to remove also. So I'll just complete my phaco here. So once I complete the phaco, I'll aspirate the cortex. This is our hybrid technique of aspiration. Little bit on this hybrid technique here, because you can use this technique here. So this is I think I'll remove my instrument. So this is the aspiration bimanual cannula. So I'll detach my aspiration tubing from my phaco handpiece, attach to the aspiration bimanual cannula without disrupting the antechamber pressure. It's very important for a difficult scenarios. And irrigation on from the phaco and aspiration for side port. You can go anywhere, and this will safeguard the difficult situation, especially subluxation also. Take out this, fill the bag, then implant the toric IOL. Normally what you do after you implant the toric IOL, because there is a viscoelastic cover, you like to remove the iris hooks first. So once you remove the iris hook, the pupil will constrict and the toric implantation may be difficult. What I'll do here, I'll remove the viscoelastic all around, fix the lens in a proper axis, then put the viscoelastic over the lens only. Then remove the iris hooks without disrupting the IOL position here. So this is image guided system, making little nicks in the capsule. This also is very important step in a smaller rexus, pseudo-explosion syndromes. These multiple nicks decreases the chance of phimosis happening in future. So these small tips are very handy in a small rexus cases. This enlarges the rexus and also prevent phimosis happening in the post-op period. I remove the viscoelastic from underneath. Now I'll put little bit of viscoelastic over. My lens is properly placed here. You can see these 3 dots here. Then I remove the iris hooks now comfortably and remove the viscoelastic subsequently. So this is how you implant the toric lenses comfortably in a small pupil where you have used the expanded devices. Remove the viscoelastic from underneath the IOL first, place the lens in a proper axis, then put viscoelastic over the lens, which you can remove subsequently without any disturbance also. So this is what you learn. Hexagonal appearance gives you a very nice appearance. Also it gives you a nice access to your emulsification, because these are 3 critical areas for your chopping and dislodging the nucleus. And injecting viscoelastic over the IOL, after you remove the viscoelastic from underneath, put the lens in a proper place and it can give you a nice access. I'll take you to the other case which I like to show you. The hard cataract case, sometimes they can be difficult here. So what I do here, after doing a proper capsulotomy And doing this is at a different case. I'll go to other case here. Yeah. No, no, no. Only aspiration, because in the Phaco you have a irrigation and a aspiration tubing here. So irrigation on, I'll detach the aspiration tubing, attached to the aspiration bimanual cannula. So irrigation all on through the Phaco handpiece only, and in that process your chamber doesn't collapse. So you avoid coming out, going in, and doing a bimanual also. So it's sometimes what happens, you have a thick epicortex, or sometimes you have little nucleus piece. This Phaco handpiece on there, I can run the Phaco also to decrease the. You can make a softer nucleus and take it out. It's very handy, and it's very swift also. So this is a hard cataract hypermature case. You can do proper staining. Rexis, you all know, should be around, and toric implantation to be done around 4.5 to 5 millimeter rexis I'm doing here. So this is how we decrease the Phaco load in these cases. This is a pre-chopping done by a My Loop. My Loop is a new technology which has come from JICE, and where we can crack the nucleus with the loop in two halves. So this is a My Loop going inside. First you take it to other side under the viscoelastic cover. Make sure it goes right up to the edge. Once you reach the edge, then you turn towards the vertical side now. Once you have vertical area, you can stabilize the nucleus with the second hand and crack the nucleus in two halves. And this second instrument is very critical to stabilize the nucleus, otherwise the nucleus will tilt up. So once you do it, it chops the nucleus in two halves. It's a very hard nucleus. You can see a nice separation. I'll take out the loop, rotate the entire nucleus to the other side, take the loop again, you can chop it, so it gives you 4 pieces. So this loop gives you 4 times you can use this particular loop. So you can use for 2 cases, sometimes you can use for 1 case only to make a multiple halves. So this is a very hard cataract. I could make it 4 chops here. The idea here is to pre-chop the nucleus so that your effective Phaco power is decreasing subsequently also. I'll aspirate the cortex here. You'll see how clean the chop area is in this case. Subsequently, I'll make the nucleus into multiple halves and chop it. So this is a very nice trick, and people should, if have access to this My Loop. Requires a little bit of learning. This is my first case only. I could do effectively. It's not very difficult. Only thing, you have to have a complete rexis, good viscoelastic cover, and make sure the entire loop goes to a capsule rexis inside, and subsequently manage these cases also. So this is under a torsional emulsification, and you can see around 50 power. You can effectively do entire emulsification of a very hard and super hard cataract also. Subsequently, you can implant the lens and do a very nice toric implantation in such cases also. I think we are almost towards the end of our session. Any questions, we'd like to answer them. Gopal Raju, you are a good cataract surgeon, and you can express your comments. Yeah, this is the mic.
My Loop it looks little scary, and then so you're saying it's a first surgery. In Titiyal's hands, it's maybe the first surgery. There's no learning curve, but in our case, I think
you have to do a little bit of hands-on training, how to press that and how to go inside, and it's quite simple. And Dr. Manpreet has also done first case only, and it doesn't really make. Only thing, the rexis should not be very small. Rexis has to be around 5 millimeters so that you have a nice axis, and don't try to pull it back unless it comes to the middle. So once you go like this, you open, and it should rotate, and it should. This was a very dense cataract, could not see the posterior limit also. But sometimes a little lesser harder cataract, you can see the posterior reflex coming from the posterior part of a loop. Then you can just pull it. When you are pulling this loop, you have to stabilize the lens. Otherwise, the entire lens tilts up. So that should be avoided. People are using in subluxury cases also. Only case where it is contraindicated a posterior polar cataract, where you have a chance of rupturing the capsule. I've seen 1 or 2 videos where capsule opens up before you do anything.
Yeah. It's actually similar to Anil Shah's snare technique.
Yeah.
The only thing in Anil Shah, you cannot do it in the back. You have to bring it over the back.
Actually, no, all these inventions are done by Indians. And people take advantage of this. I've seen this video in American Academy and AICRS in the USA, where Arup Bhaumik from Desai Hospital, he started this snare technique. He modified his own way to do it. It was very effective. In fact, he won the best video award in AICRS. But Jai's people have taken a clue from there, and they have now patented this technique under them.
We do get these type of cataracts in plenty, so that may be the other reason.
Only thing is become a costly, it costs you extra few thousand rupees per patient.